Ευχαριστώ πάρα πολύ για την πρόσκληση και συγχαρητήρια για το συνέδριό σας. Είναι πάρα πολύ ενδιαφέρον και είμαι πάρα πολύ χαρούμενος που είμαι εδώ μαζί σας. Συγγνώμη, θα κάνω την παρουσίαση στα αγγλικά, αλλιώς δεν θα χωρέσει τα 20 λεπτά. Τα ελληνικά μου στη ιατρική είναι αρκετά μέτρια. Λοιπόν, τι μπορούμε να πούμε για Interventional Radiology in the area of immunotherapies? You all know that immunotherapy has changed the paradigm in cancer treatments, and it provides, of course, responses. You can see the example of melanoma, but it also provides cures for some patients. But what's interesting is that for some of these patients, and most of them actually, there are some limitations, there are some drawbacks. And the main drawbacks are that although immunotherapy has changed the paradigm, it only responds for about 20–30% of the patients. The second drawback is that you have lots of toxicities that we call immune-related toxicities. And the third drawback, which is not a small one, is the price, the cost. Actually, immunotherapies cost a lot. So we can see how, by using interventional oncology, you can overcome some of these drawbacks. So I'll divide my presentation in 4 topics. I'll start with biopsies. You all know that we perform biopsies. Then we'll discuss very rapidly on local administration of immunotherapeutics. Then the combinations, and we'll touch base on radioembolization and immunotherapies before giving some glance on what we can do in research. So first of all, biopsies. Immunotherapies have changed the way we treat patients, but to do that, we need to have biopsies for patients' tumors. You need to have them either to analyze the microenvironment, either to see if the tumors will express the targets of your treatments. For instance, when you have a patient with cancer, lung cancer, you need to know the expression of PD-L1 on tumor cells. Of course, it has changed a lot. You have combinations, and it's becoming mainstream. But very schematically, a patient has biopsies at the diagnosis of his cancer. He will have biopsies when he's included in trials, and sometimes on treatment to see if he responds as predicted. And in order to analyze the mechanism of response, or if he doesn't respond, resistance to immunotherapies. And finally, you even perform biopsies to analyze toxicities. So a typical patient treated for cancer will have 1, 2, 3, 5, 6 biopsies during the treatment of his whole disease. So and these samples will allow all the fancy analyses such as phenotyping, transcriptomics, or analysis of the somatic mechanisms of escape of tumors. This is the first set, and this is why you are friends with your interventional oncologist. It's about, I don't know, 1/3, 1/4 of what we do in interventional oncology. Then, when you move to the therapeutic area, we'll see that you can administer immunotherapies locally. And this is what we do in interventional radiology. We're able to puncture whatever you want, namely. And this has started more than a century ago. You all know William Coley that treated cancer with bacteria by injecting bacteria into the tumors, and he showed excellent responses by stimulating the immune system. And actually, we're doing that in patients. On the left part of the screen, you can see a patient with a melanoma. The lymph node is very hypoechoic, it's very dark, and you can see the product that is being injected. In this case, it's anti-CTLA-4 antibodies, it's ipilimumab. And you can do that in lymph nodes, superficial lesions. You can do that for lung tumors. You can do that for liver tumors, etc., etc. So to go and administer immunotherapies locally, and I'll show you, has some rationale to overcome this resistance, this non-responser, to decrease the immune-related adverse events. And of course, it can decrease the cost by increasing the efficacy locally. And local immunotherapy is interesting because it avoids non-target complications and exposure to immunotherapies, thus diminishing the side effects. So this is what we call use the tumor as its own remedy, because you will stimulate the tumor itself and you will make it more easily recognizable by the immune system by decreasing toxicity, increasing efficacy, and do all these synergistic treatments that we have seen. So let's see, this is a patient. This is interesting because when you use RECIST criteria to evaluate the responses of your treatments. When you have a patient with all these diseases, on the first example, the patient has 5 lesions. You will inject 2 of these tumors locally. And although if the patient responds, if he increases on other lesions or if he presents his new lesions, the patient will be classified as a non-responder. So you will need to change the strategy and change the therapy. So although he has responded, and you can inject the other lesions and so on and so on. So usual criteria does not allow to evaluate the response to local therapies. And it's the same for ablation. It's the same for local regional therapies. You need to adapt your criteria to assess the treatment you're performing. And to do that, we have defined what we call the IT RECIST criteria that we have published in GCO last year, 2 years ago, showing that you need to take into account which lesions have been injected and which not. And you have discussed on MDTs, and we even have a multidisciplinary tumor board for local immunotherapies in our place that help us how to better choose the injection, the lesion we injected, the amount of product we injected, and how we'll evaluate the response. Those are 2 examples. Patients with many lung mets. It was a patient with melanoma. We injected 1 lesion, and you've seen that all the lesions on the lung CT and the PET CT disappeared. Same, another young patient, 30-year-old man, with a deep-seated lesion in the mesenteric area. So you can promote immune responses, systemic immune responses, by injecting 1 or 2, a few lesions. Then, of course, you can discuss about technique. There are different ways on how you will inject to have a better distribution of the product into the tumors, but those are technical issues that for most interventional radiologists are quite easy. And of course, you can do that percutaneously, you can do that intra-arterially, you can even inject into cavities. There is a very nice study in the Sloan Kettering group for mesothelioma, patients with pleural mesothelioma, by injecting CAR T cells into the pleura with very nice responses. And nowadays, we have access into the lymphatic systems by performing lymph angiographies, and you can even inject lymph nodes and the lymphatic system. Based on that, we have built a clinical trial called IPANIV. It's actually ongoing, it's almost finished, and we have injected intra-arterially immunotherapies for patients with HCC. So the results are not published yet, but it is safe. And now we're analyzing the responses and all the translational results to see if it brings any favorable results for these patients. Third area, and this is probably the most straightforward, the more easy to understand, is how you combine interventional radiology and the systemic therapies. And this is what we were discussing previously. There are lots of data, but if you look in a more theoretical way, by burning a tumor, by ablating a tumor, by injecting locally and creating some ischemia, creating some immunomodulation, you will increase the exposure of tumor-associated antigens to the immune system. And if you have patients under immunotherapy, there are high percentages of synergies in these tumors, in these settings. And this has been nicely shown a few years ago, 6 years ago, from the study coming from Bethesda. It was a GEP in 2017, showing that when you combine an anti-CTLA-4 antibody, in this case it was tremelimumab from AZ, with local treatments, there was a group with ablation, radiofrequency ablation or cryoablation, and a group with TACE, that showed that it's feasible, it does not increase the complication rates, and it brings some responses. Those patients were heavily pretreated HCCs, and they showed a 25% objective response rate. And even when you looked the per patient results, there were some very nice clinical results. And of course, all the translational results confirm this immune activation by local treatments. When you combine cryoablation, radiofrequency ablation, or chemoembolization, you will stimulate the immune system. And a few weeks ago, we had the results, at least the announcement of the results of the Emerald trial. I don't know if you were aware of this trial. This is a phase 3 randomized trial for the oncologist, comparing chemoembolization plus immunotherapy, chemoembolization plus immunotherapy and an anti-angiogenic drug versus placebo and chemoembolization. And we had the results that have been at least announced a few weeks ago, and this trial is positive. This trial is positive both on the primary endpoint, which is PFS, and the response, I hope so, will be significantly enough even to improve the overall survival of these patients. So for HCC patients, intermediate stage HCC patients, the new standard of care in very few months will be combination of chemoembolization and immunotherapy. So all that we were waiting to see how it combines, how it synergizes, and all the data we're showing on preclinical or small cohorts will take place with these results. So it's a major advancement in this combination. And so let me show you a case just to brainstorm. This is a patient with an advanced HCC, and the question is there room for CIRT, for radioembolization, as Professor Cazzano showed that just previously. So I'm showing you the case, and just a specific consideration for all the HCC patients that are BCLCC, so advanced disease, but with no extrahepatic spread. So the clinical scenario. Young patient, 59 years old man, quite okay in general status. He has a diabetes type 2. He drinks a little alcohol, has no hepatitis. Some liver enzymes are elevated, and diagnosis of a left hepatic HCC with no extrahepatic disease. So I'm showing the CT scan, 5-centimeter tumor in the left lobe, portal vein of thrombosis of the segment 3, AFP at 600, so quite elevated. Some static images, CT, there is a wash-in, there is a wash-out, you have the portal vein thrombosis, no doubt, it's an HCC. You have the morphological features, it's Lyra, it's 4, 5, I don't even know. And we perform the biopsy because at our place we're performing biopsy almost for all the patients for clinical trial purposes. On the liver biopsy, it says it's a well-differentiated HCC with very few lymphocytes. This is important, with underlying steatosis and a slight fibrosis. So, what would be your treatment option? Do you go for tumor ablation? We've seen with Professor Philippiadis' presentation that we have very nice results, but you have the portal vein thrombosis, quite large lesions, very active disease with high AFP. Would you go for chemoembolization? We know that when you have portal vein thrombosis, it's probably not the best treatment for these patients. although in Asia and in Japan, they're performing chemoembolization for these kinds of patients. Would you go for radioembolization? And based on the previous talk, we will all go for radioembolization, I suppose. Systemic treatments. It's an advanced patient. Normally, you should say it's an atezo-bev patient. But are you sure this is the best option for this patient? Liver transplantation, in a second way, if you bridge the patient to transplantation, why not? And surgical resection, we know that for patients that have portal vein thrombosis, the recurrence rate is very high. So in our place, and based on what's recommended on the BCLC algorithm and the ESMO guidelines, for patients for whom we consider that other treatments are not the best options, you can consider radioembolization. And we went for radioembolization. In this case, we did a radial approach, and you can see the very nice uptake both on the workup and the post-treatment PET-CT with the absorbed dose, which wasn't that high. It was using CISFER 156 grays. We could have gone higher, but still, we had at 3 months, we had a complete response, at least morphological complete response, that maintained at 6 months. And we discussed exactly what you said before. The patient is in very good shape. He responds completely. There is no other recurrence. Would you go for resection after that? And we went for resection. He had negative alpha fetoprotein. He was good for performance status, no portal hypertension. So we did our surgeon did a left hepatectomy. And what's interesting, it was a macrotrabecular massive HCC, and there was something 10% of viable tumor cells. So we're happy on doing the resection after that. But what is very interesting is that this patient, on the surgical specimen, he has a lot of intratumoral lymphocytes. And the expression of PD-L1, which was negative on the biopsy, was massively expressed on tumor cells on the surgical resection piece. So this is an experimental setting to show you that when you treat locally a patient, in this case with radioembolization, you will stimulate the immune system. You will induce PD-L1 expression, and you will bring the lymphocytes to the tumors intratumorally specifically. And this is the rationale to combine radioembolization and systemic therapies. And we have now this trial ongoing, which is the OLM-BRAVE trial. We have included 10 patients nowadays, which combines atezolizumab plus bevacizumab with a radioembolization between cycle 1 and cycle 2 at first line for patients with advanced HCC. Finally, in 1 minute, I would like to share with you some research perspectives very rapidly, just to show you that there is a lot of stuff ongoing on imaging and developing devices to better distribute immunotherapies into the tumors. And we are developing platforms to be able to inject locally and have controlled release of immunotherapies. And this is probably, we make, as it's usually done for chemoembolization, emulsions between lipiodol, and by adding nanoparticles, nanomedicine, as Professor Philippiadis said, we're able to make continuous release of immunotherapies into the tumors with very nice data on mice experiments, and we're trying to translate that to human patients. And this is probably what we will call immunoembolization in the next few years. And one last thing, because here in IGIA, in Mitera, you have a nice experience on on PET imaging and nuclear medicine. You do not need, it's important not to miss immunopet imaging. Immunopet imaging is very interesting where you're interested in local treatments, immunotherapies, and cancer imaging. We are now able to label immune drugs and see the distribution into the tumors and predict responses. And it's very interesting for us radiologists to know which tumor, to predict which tumor will respond to a treatment, and if not, to be able to treat them locally with ablation, chemoembolization, radioembolization, etc. This is probably the best way to select our patient. And we've done some studies in our place, but once again, keep that in mind. Probably it will come as a biomarker to all these fancy new immunotherapies. Thank you very much for your attention.
Κύριε Τσέλικα, ευχαριστούμε πάρα πολύ για την εκπληκτική παρουσίαση. Και τώρα θα είμαι ανυπόμονος να ακούσω για τα σχόλια. Ιδίως των άλλων ειδικοτήτων.
Ακούσαμε μια εξαιρετική ομιλία πραγματικά. Μέχρι και οι φίλοι μας οι ογκολόγοι πιστεύω ότι έχουν ευχαριστηθεί. Σχόλιο ο κύριος Κροκίδης.
Τι πρέπει να περιμένουμε για να μπορέσουμε να ενσωματώσουμε την ανοσοθεραπεία σε σφαιρίδια? Γιατί δεν μπορούμε να πάμε σε σφαιρίδια? Ποιο είναι το βασικό πρόβλημα, το μοριακό βάρος?
Είναι και οι χημικές και οι φυσικές αντιδράσεις των ανοσοθεραπείων και των φαρμάκων και των σφαιριδίων που δεν μας επιτρέπουν να κάνουμε load immunotherapy στις beads και μέχρι τώρα δεν μας επέτρεπαν ούτε με το lipiodol. Αναγκαστήκαμε με κάποια τεχνάσματα να δημιουργήσουμε αυτές τις καινούργιες emulsions για να καταφέρουμε να φορτώσουμε ημουνοθεραπείες στα σφαιρίδια.
Αυτό που δείξατε πάνω είναι ο κλασικός τρόπος ανάμειξης.
Κλασικός, πρέπει να προσθέσεις κάποιες nanoparticles, αλλιώς που προστατεύουν την ανοσοθεραπεία, αλλιώς το lipiodol την καταστρέφει πάρα πολύ γρήγορα.
Μάλιστα, ειδικό μήνυμα λοιπόν.
Απλώς είναι τελείως διαφορετικό το να κάνεις ένα device trial από το να κάνεις ένα drug trial. Δηλαδή και στο σχεδιασμό και στον όγκο και το drug delivery είναι τελείως διαφορετική φαρμακοκινητική από το ότι κάνουμε, και γι' αυτό και οι περισσότερες μελέτες που έχουμε είναι devices, γιατί είναι διαφορετικό τελείως το κόστος και είναι χάσμα ανάμεσα στις δύο μελέτες.
Κύριος Φιλιππιάδης.
Να κάνω μια ερώτηση. Όσον αφορά την αποτελεσματικότητα του ablation, νομίζω ότι όλοι συμφωνούμε ότι είναι ο πιο δημοκρατικός τρόπος νέκρωσης. Όλες οι τεχνικές ablation σκοτώνουν όλους τους όγκους, δεν υπάρχουν ablation resistant όγκοι. Όσον αφορά το συνδυασμό με ανοσοθεραπείες, υπάρχει κάποια elite, δηλαδή ίδιο impact έχει η κρυοπηξία, ίδιο impact έχουν τα μικροκύματα και να βάλω και στο παιχνίδι τα electric fields, pulsed και permanent.
Ναι και όχι. Πάντα. Θεωρητικά δεν έχουν τον ίδιο τρόπο να κάνουν stimulate το immune system κάθε ablation method. Οι πιο πολλοί λένε ότι η κρυοθεραπεία είναι πιο αποτελεσματική επειδή κάνει preserve όλα τα στοιχεία του όγκου και είναι πιο καλά αναγνωρίσιμα από το ανοσοποιητικό σύστημα. Από εκεί και πέρα δεν υπάρχουν κλινικές μελέτες που να αποδεικνύουν ότι το ένα είναι καλύτερο από το άλλο. Όλοι όμως οι ablation methods κάνουν stimulate το immune system. Οπότε και η radiofrequency ablation και η cryotherapy και ακόμα περισσότερο σε πρεκλινικές μελέτες η IRE, η electroporation κάνουν immune stimulation. Από εκεί και πέρα πρέπει ας δείξουμε πρώτα ότι υπάρχει κάποιος τρόπος να τα συνδυάσουμε και από εκεί και πέρα θα δούμε ποια από τις τεχνικές μας είναι η καλύτερη. Όταν κάνουμε locoregional therapies, καλύτερα να κάνεις ραδιοεμβολισμό παρά χημειοεμβολισμό. Ειδικά που χημειοεμβολισμό, ανάλογα με τη χημειοθεραπεία που επιλέγει ο καθένας, το immunogenic cell death δεν είναι ακριβώς το ίδιο. Από εκεί και πέρα, ας ξεκινήσουμε με 1, 2, 3 πρώτες μελέτες που να μας δείξουν ότι υπάρχει αυτή η synergy μεταξύ των therapies και μετά θα δούμε ποια από όλες είναι η καλύτερη.
Κάποιο άλλο σχόλιο, κύριε Συρίου?
ίσως είναι ο καλύτερος τρόπος για να κάνεις ένα non-immunogenic tumor immunogenic. Δεν υπάρχει καλύτερος. Άρα με αυτή την έννοια δεν θα βάζα το χημιοεμβολισμό, γιατί θέλω πολύ ενεργό ανοσοποιητικό σύστημα, δεν θέλω να το καταστήλω. Η ερώτησή μου είναι η εξής. Έχουμε τη βλάβη, καταστρέφουμε τα κύτταρα, διηθούμε μετά φλεμφοκύτταρα, αλλάζουμε το PDL status, καταπληκτικά όλα. Αν υπάρχει μία βλάβη σε ένα άλλο όργανο ή δίπλα, θα μπορούσε να αλλάξει το ανοσολογικό στάτους και της άλλης βλάβης, παρότι δεν την πειράξαμε, σαν ένα είδος bystander effect?
Ευχαριστώ πάρα πολύ για την ερώτηση. Είναι πάρα πολύ ενδιαφέρον και όσο περνάνε οι μήνες και τα χρόνια, μας ζητάνε οι ογκολόγοι μας να κάνουμε βιοψίες όχι μόνο στους όγκους που θεραπεύουμε, αλλά και στους distant όγκους. Και από ό,τι βλέπουμε, η immune activation είναι systemic. Δηλαδή και στο αίμα και στο... Δηλαδή όταν λέμε ότι η RFA είναι local treatment με systemic effects. Οπότε το ξέραμε για το χειρουργείο. Το χειρουργείο είναι λίγο ανοσοκατασταλτικό, που η ablation δεν είναι το ίδιο. Από εκεί και πέρα, το κατά πόσο είναι σε ίδιο βαθμό στον όγκο που θα κάνουμε ablate ή θα κάνουμε radioembolize και στον άλλον, δεν είμαστε σίγουροι. Από εκεί και πέρα υπάρχουν effects και στους άλλους όγκους.
Έχετε κάποιο τρόπο πριν από τη ανοσοθεραπεία, είτε local είτε μάλλον local εσείς, να κρίνετε αν θα επιδράσει θετικά ή δεν θα έχει toxicity?
Έχουμε και αυτό είναι εργαστηριακά, αυτό κάνουμε όλη μέρα, κάθε μέρα. Προσπαθούμε να κάνουμε predict ποιος θα ανταποκριθεί και ποιος όχι. Έχουμε όλα τα prognostic factors είναι γνωστά, ότι αυτός ο τύπος όγκου, όταν έχουμε αυτή την extension, όταν έχουμε αυτό το phenotype, οι ασθενείς ζουν περισσότερο ή λιγότερο. Αυτά είναι prognostic factors. Αυτό που μας ενδιαφέρει τώρα σιγά-σιγά είναι να κάνουμε predictive factors για συγκεκριμένες θεραπείες. Και σιγά-σιγά έχουμε αρχίσει και βγάζουμε μερικά phenotypes. Ξέρουμε, για παράδειγμα, ότι για το μελάνομα που θα δώσουμε anti-PD-1 και anti-CTLA-4, άμα έχουν high Treg expression μέσα στους όγκους, θα ανταποκριθούν.
Από τη βιοψία δηλαδή.
Από τη βιοψία. Οπότε οι ογκολόγοι μας ζητάνε πάντα βιοψίες πριν να ξεκινήσουν ανοσοθεραπείες. Και το immunopet που σας έδειξα στο τέλος, μάλλον θα είναι το απεικονιστικό predictive biomarker για πολλές από αυτές τις ανοσοθεραπείες.
Ωραία, να προχωρήσουμε. Ευχαριστούμε πάρα πολύ, κύριε Τσελίκα. Μας δώσατε μια μεγάλη εικόνα από το μέλλον.